Hey everyone, welcome back to part 29 of our 100-part CPC exam series. Today, we're diving right into our explainer on the musculoskeletal CPT coding section. It's a big one, so before we get into the heavy lifting, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's get into it.
Here's our game plan for today's explainer. 1. The musculoskeletal landscape. 2. Cracking fracture rules. 3. The arthroscopy bundling trap. 4. Navigating spine surgery. And 5. Our visual coding cheat sheet.
Okay, Section 1, the musculoskeletal landscape, Section 20,000 to 2999. So, let's map out our territory, right? I really want you to anchor your memory to this specific numerical block, 2,000 to 29,999. You know, when you're totally time crunched on the CPC exam, just knowing off the top of your head that this is exactly where the musculoskeletal system lives, well, that's going to save you precious minutes when you're frantically tabbing through your book. The CPT manual actually organizes these surgical codes pretty logically. It basically mirrors human anatomy, flowing geographically straight from the head and neck all the way down through the feet and toes. But you really need to pay attention here because it also carves out these special rule-heavy subsections for general procedures, the spine, strapping and casting, and arthroscopy. All right, moving right along to Section 2, cracking fracture treatment rules, open versus closed. Now, what's really interesting here is our first major exam trap, differentiating how a fracture is treated surgically. A massive pitfall, and I see this all the time, is assuming this has something to do with what the fracture actually looks like on an X-ray. It absolutely doesn't. Closed treatment literally just means the fracture was treated without any surgical incision at the site. Conversely, open treatment means the surgeon actually made an incision to expose the bone and do some internal work. So the golden rule? Never ever confuse an open fracture diagnosis with an open treatment surgical code. You also need to train your eyes to scan those exam scenarios for one critical trigger word: manipulation. This strictly means the provider had to physically reduce or realign the bone. Think about it. If they just casted the arm exactly as they found it, that's treatment without manipulation. Simple as that. So think about the whole life cycle of fracture care. Establishing this billing rule early is absolutely vital. The physician's initial cast or splint application, that is always included in the global surgical package. You do not bill for it. However, replacement applications during follow-up visits are separately billable using the 29,000 series codes. Oh, and don't forget the middle ground here, percutaneous skeletal fixation. That's where pins are driven straight across the fracture without a full surgical exposure. Up next, Section 3, the arthroscopy bundling trap. Look before you code. Okay, we have officially arrived at the most heavily tested bundling rule in the entire CPT manual. Let this be your absolute golden rule. A diagnostic arthroscopy is always included in a surgical arthroscopy in the same joint. Seriously, if the surgeon performs a surgical scope, like a repair, you never ever bill the diagnostic look-around separately. To unbundle this stuff properly, you really have to understand compartment specificity. Take the knee, for example. It's got 3 distinct compartments: the medial, the lateral, and the patellofemoral. Multiple surgical procedures can only be coded separately if they occur in distinctly different anatomical compartments. If they're in the same compartment, boom, they are bundled. And here is the classic exam trick they'll use to bait you. The vignette will explicitly say the surgeon looked around first or performed a diagnostic scope right before performing the repair. Guys, do not fall for it. That language does not magically make a diagnostic scope separately billable if they immediately followed it with a surgical scope in that very same compartment. Moving on to Section 4, navigating spine surgery codes, building the claim. Navigating spine surgery requires a highly formulaic approach, so you don't miss out on those complex add-on codes. And this brilliantly illustrates how building a spinal claim is really just a logical step-by-step process. Step 1. Code the primary procedure for your first interspace or segment. Step 2. Report add-on codes for each additional level. And Step 3. Report add-on codes for the instrumentation and grafts used. When you read a spinal operative report, you kind of have to act like a detective. You're hunting for these specific details, like what was the surgical approach? Was it anterior, posterior, or lateral? What type of instrumentation was used, segmental or non-segmental? And what kind of bone graft? Autograft from the patient or allograft from a donor? You gotta know this because spinal instrumentation and bone grafts are almost always reported as distinct, separately billable add-on codes. And finally, Section 5, Visual Coding Cheat Sheet, Musculoskeletal Mastery. We're wrapping up, so definitely take a screenshot of this summary. The crucial points are all consolidated right here. Let's recap. For fractures, differentiate open versus closed treatment and strictly scan for manipulation. For arthroscopy, remember the diagnostic scope is always bundled into the surgical scope in the same joint. And for the spine, build your claims sequentially. Primary approach first, then add on levels, then add on hardware. You all did incredible work today navigating these traps. But think about this for a second. If just one single word, like manipulation, can completely change a musculoskeletal claim, what hidden vocabulary is waiting to trap you in the lungs? So, what does this all mean for our next deep dive? Are you ready to tackle the respiratory system next? We'll be covering nasal procedures, endoscopy, bronchoscopy, and lungs. I'll see you in part 30 of our explainer series to conquer those codes. Keep studying hard, and I'll see you next time.